Okay, welcome back. And again, thanks for joining me for today's webinar. My name is Dr. David Kunashko. I'm the Medical and Innovation Director here at BioFlex Laser Therapy, North America's first photobiomodulation red light therapy device company, believe it or not. And I do two types of webinars typically every month. I do one for healthcare professionals that typically have our professional equipment or interested on a professional level, although anyone can listen in. That's what today's topic is more geared towards. So a little bit more medical terminology, that kind of thing. And I also do webinars for consumers that use perhaps consumer devices at home, like our BioFlex Wave line of products as well. And so that's typically what I do. These are recorded, edited, and then they're uploaded onto our website. So should you want to watch again or watch some of the archived webinars, just go to bioflexlaser.com, look for support, top right, and then you'll see the archived webinars right there. As usual, the webinars are about half an hour to 40 minutes in length. You can ask questions along the way, put those in the chat box, and I'll get to those at the end of the webinar. Okay, so excuse me, today's webinar is on rosacea. I thought it was an interesting topic because it's come up, I'd say, a fair amount over the 15 years that I've been involved in with photobiomodulation. And, you know, rosacea is a really interesting condition. And those of you who maybe have it or know patients or typically patients that have it, you know, it's challenging for them on many different levels. And of course, there's medications, and I'll talk a little bit about that. But there is a fair amount of evidence to show that what we do, that is laser therapy or photobiomodulation, can really help in different ways in a very safe kind of type of therapy. So I'm going to talk about that today. Typically, when I talk about conditions, I'll go over the etiology, pathophys, and symptoms, a little bit about the epidemiology as well. And I typically will talk a little bit about some of the current evidence-based treatments, non-laser or non-low-level laser kind of approach. And then specifically how PBMT or photobiomodulation can help this condition. I try to share some research if there's published research, which there is a little bit on this topic. And then I'll get right into how you would use your equipment to treat patients with rosacea. Little quote that the global prevalence of rosacea is, I've seen it vary, but it's roughly 5.5, 5.4%. It's the highest in a group of adults between 25 to 39. So it's usually more as we get older. So the prevalence is greater as you get older. But it can occur in younger ages as well too. There seems to be definitely more common in women, females compared to males, and more at like 5.9% versus 4.4%, respectively. You can see the stats there from rosacea.org. So rosacea is a chronic, but it is to a large degree treatable skin condition. It primarily affects the central face. And also it's often characterized by flare-ups and remission. So it's one of those types of things that, you know, like maybe eczema and some other conditions that can be really bad and flare up and then get better and you're okay. And then all of a sudden there's a trigger or something that goes on that makes it flare up again. So the rosacea is pretty similar to that pattern as well. It can develop in many ways and again at different ages. They've done a lot of patient surveys. And oftentimes it begins after the age of 30, as I mentioned, and the patients will start to have some flushing or redness of their cheeks, nose, chin, or forehead, which may come and go. Those are usually the first signs. Fair-skinned or Caucasian, I don't think nowadays, you know, you have to be careful what you say, but I think even Caucasian is probably not the correct term if you look historically at it. But anyway, with fair skin and Fitzpatrick skin types between 1 and 2, and those with photosensitive skin types appear to be a greater risk for rosacea. As I mentioned, it's most prevalent as you get older, especially above the age of 65. When it is, occurring at an older age category, that you tend to see various comorbidities, including cardiovascular issues, GI issues, neurological, psychiatric, autoimmune, and even some types of cancer as well. Now, of course, part of that is they're older, so there's that too. But I think there's definitely also well-known comorbidities that are known to go alongside with rosacea at an older age. The pathogenesis is really not overly clear because there's lots of different factors, and they're still doing lots of research on it. However, they do feel that it's a multivariate set of pathogenic pathways. They know of these pathways upon studying them, especially in mice and other animal models. And typically it involves defects or issues, so genetic issues with the innate and adaptive immune systems, sometimes mast cell. The hallmark of rosacea pathogenesis is its association with a skin barrier and permeability dysfunction, including changes in skin hydration, pH, the microbiome, and various components of the skin's molecular structure. So that being said, part of the way of perhaps helping rosacea patients manage it and reduce flare-ups, that kind of thing, is taking care of the skin itself using different either medicated creams or over-the-counter creams that can address some of these issues. Again, not completely understood etiology-wise, but again, it's usually they feel it's a combination: genetic, environmental, inflammatory, microbial factors. It could be several of these or many of these that ends up causing the issue. One example is a dysregulation of the innate and adaptive immunity. There are toll-like receptor 2 overexpression, and this causes an increased inflammatory response. There's LL-37, which is a cathelicidin dysregulation. This can trigger abnormal inflammation and angiogenesis. Now, I want you to note, as we're talking, you'll see a lot about inflammation, and that's the key to how photobiomodulation can of condition. There's also T helper cell immune responses. These also contribute to chronic inflammation. Then there's neurovascular dysregulation. This is abnormal vasodilation due to what's called TRPV ion channels, and also dysregulation of nitric oxide, which you probably also know is a fundamental principle of how photobiomodulation works, is modulating nitric oxide levels. And substance P. These can cause flushing and erythema. This oftentimes is triggered by things like excessive heat, prolonged heat, even stress, or even spicy foods. So if you enjoy those kinds of foods and you're prone to rosacea, then you probably should be avoiding that. Then there's microbial factors. Mites, Demodex floriculum mites, when you have increased colonization of these, they can trigger rosacea. This probably has to do with immune response with respect to these mites. There may be involvement, bacillus and staph may be associated as well with inflammation. I did notice one research paper used blue light, and I think it did that because of the potential bacterial involvement. So that was interesting, I thought. And then there's gut microbiome alterations as well. There might be a systemic influence. Now, I didn't specifically talk about treating the gut for treating this condition, but I think it's interesting that you should consider doing that as well if you have a chance to. And I do have webinars previously on treating the gut, so you can just refer to those as well. And of course, there's genetic predisposition. I mean, that kind of makes sense. There might be immune-related genes that are affected, that kind of thing. We know that there can be environmental and triggering factors such as excessive UVB radiation. This can upregulate pro-inflammatory cytokines and MMPs. And again, if you're a fan of a photobiomodulation, you know that it actually can decrease pro-inflammatory cytokines and decrease MMPs as part of the mechanism, the well-known mechanism. So right away, you start to see where photobiomodulation can help this type of condition. And as I mentioned before, the spicy foods, but even alcohol and stress, these kinds of things can worsen vasodilation and flushing. Then there are skin barrier dysfunction. This can lead to increased sensitivity to irritants, even just regular makeup or different things you put on your face. These may then. There are some other factors, rosacea-like conditions, steroid-induced or mast cell activation. So not true rosacea, but kind of it mimics it. And there might be hormonal influences as well. Not overly clear, but perhaps perimenopausal women are more affected. They still need to kind of get a handle on that. If you look, and I pulled this from rosacea.org, but if you look at the most common triggers by percentage, you can see sun exposure is the #1 thing. So you need to really be careful with that, and emotional stress. And then, hot weather and wind and heavy exercise, that would be prolonged exercise, and alcohol. Really have much fun at all, can you? I just need to, be careful. That's all. Spicy foods, humidity, all these kinds of things. So if the rosacea.org is a great resource, so you can always direct your patients to that as well too. There are different types of rosacea, sort of 4 main subtypes or categories. The first one is is a long one. I'm not even gonna erythema rosacea. I don't know. It's not bad, I guess. It's characterized by persistent central facial redness, so erythema, and visible blood vessels. You can see the little spider vessels there, and oftentimes includes flushing and sensitivity. I'm sure you've seen, if you've never treated this condition, I'm sure you've probably noticed these signs and symptoms in people just walking about, that kind of thing, because it's fairly prevalent. Another subcategory is papulopustular rosacea. Almost looks like acne to some degree. Persistent facial redness along with transient papules, so small red bumps and or pustules. And again, often mistaken for acne. But unfortunately, like Accutane and the acne medicines, which are more for antibacterial, they tend not to do a lot for this. So it's not usually recommended. Phymatous rosacea. This is kind of more in an advanced category, and you may have seen pictures of this, especially if you're a fan of art and you see some famous paintings. You see people with rosacea. I don't know if you've ever seen those paintings or not, but I just remember being at some galleries and seeing some of these old paintings that you can tell, oh man, that person has rosacea. And this involves skin thickening and nodularity, so lumpy skin enlargement, most common in the nose and chin and forehead. Can lead to something called a bulbous nose, especially in men. Last category is a nasty one, ocular rosacea. It affects the eyes and eyelids. It can cause chronic inflammation, burning and stinging, dryness, itching, and blurred vision. And it may also include periorbital edema, swelling around the eyes, and even telangiectasia in the eyes, so little blood vessels in the eyes as well too. So evidence-based wise treatment, it's really revolves around topical and oral medications. The first line from mild to moderate, you can see there's a bunch of medications. I think everyone's heard of ivermectin because that was the big COVID. I'm not going to comment on that, but you can see these ones oftentimes are used. I'm just mentioning those because you should be aware of them. There are oral medications. This tends to be when a condition is a lot more severe, so moderate to severe. So doxycycline, isotretinoin. Oh my, okay. So I'm at low battery. Hang on 1 second here. I have 2 ports of my computer, only one works. So I don't know. There we go. And then there are laser and light therapies. Now, I'm going to be clear. These are not low-level laser therapy. These are pulsed dye lasers, intense pulsed light, YAG lasers. These are ablative or higher powered. There's tons of research on this, and it can be quite effective. The problem is it can cause refractory redness, it leaves scarring. There's other issues with this, although it can be effective depending on how it's used and everything. But this is definitely a subcategory of treatment out there that dermatologists oftentimes will use. It's just compared to low level, or I'm not talking low level therapy here at this point. And then there are some general skin care and trigger avoidance. So as obviously you want to avoid alcohol and fragrance, harsh exfoliants. You need to always make sure with respect to sunscreen that you protect your face. Make sure you don't react to that sunscreen. There's some really good ones that tend to be expensive that are made very well that don't have any irritants in them. And of course, avoid the triggers that we've talked about earlier. How would photobiomodulation help rosacea? Well, I'm not going to go into the ins and outs of the mechanisms other than just a general understanding of how photobiomodulation works. So we know that red and near infrared light, it can be absorbed by photoreceptors inside cells. And typically the one we're most interested in is the second terminal enzyme, CCO, or cytochrome C oxidase, which ad nauseum I've talked about this, but of course it's critical because in inflammatory cells, which is what's going on here, these cells actually have a mitochondrial issue because you have a buildup of nitric oxide intracellularly, and this will cause all sorts of problems. So what light therapy does is it helps to reverse this or help it. And it does that by releasing nitric oxide where it's binding and inhibiting cytochrome C oxidase. And nitric oxide is a very short-lived molecule, like 5 to 6 seconds before it dissociates into nitrogen and oxygen. So as you're sort of releasing nitric oxide, that's my three-dimensional version of it, then oxygen can start to bind back on aerobic respiration. Now, when you don't have aerobic respiration, you have anaerobic respiration and release of lactic acid, which again is not a great thing to have and a contributing factor to rosacea. So by helping the health of the skin, and this is what's really going to help these patients with their symptoms. And there's a whole trickle-down effect here. Once you make more ATP, you also release certain types of stress proteins that help the cell protect the cell from further cellular damage. So it all revolves around absorption by wavelengths. Blue light, which I mentioned earlier, the pathway for this is a little bit different, and to be honest, it's probably used more for an antibacterial effect than a photobiomodulation effect. So PBMT, or photobiomodulation, can reduce inflammation. And because rosacea is driven by chronic inflammation and immune system dysregulation, it can be very helpful. It can help downregulate pro-inflammatory cytokines. Just some examples here, like interleukin-1 beta and interleukin-6 and tumor necrosis factor -alpha. I love these names. I wish I could have made up some of these names, but anyway. And it promotes anti-inflammatory mediators, and by doing this over a period of time, it helps calm the skin flare-ups. When I talk about the protocol, you'll see it's much longer than the standard protocol, and really that's because you want to treat the skin a little bit longer and to see basically to stimulate this kind of anti-inflammatory effect. It's more of a overall effect on the area, on the skin. I'm going to say to some degree a systemic effect, but also directly into the cells as well. It can also improve microcirculation and vascular stability. So we know excessive facial flushing and visible blood vessels are a key feature of rosacea. Photobiomodulation can help normalize blood flow by strengthening blood vessel walls and reducing vasodilation on an ongoing basis. It can also reduce nitric oxide overproduction. And really this has to do with reducing inflammation, which reduces nitric oxide as a byproduct of inflammation. It can also stimulate skin repair and collagen production. And again, this goes because of when you increase ATP, you increase metabolism and the ability of fibrocytes that that make collagen to promote their health and metabolism. And it can reduce oxidative stress. We know that rosacea skin often has elevated ROS, worsening inflammation, and photobiomodulation upregulates antioxidant enzymes, specifically superoxide dismutase, and this helps to neutralize these free radicals. Oops. I should turn off all my notifications. And the other thing about photobiomodulation is there are minimal side effects, and it's pretty safe for sensitive skin. Unlike lasers that generate heat, sorry, I was just thinking about something there. Unlike lasers that generate heat, like the ones I mentioned earlier, like the pulse dye laser or IPL, we know that PBMT is essentially cold laser, right? There's no heat being produced. So it makes it very suitable for rosacea-prone skin when you don't want to heat up the skin to any great degree. A bit of warmth is fine. I'm talking about hot, like prolonged heat. And typically it won't cause rebound, redness, and irritation that some of the can produce. There is some research. I'm going to be straight up front. Like there's not tons of human trials, a little bit, but mostly like cell and animal model research, but it's still relevant. First one is on the effects of photobiomodulation on inflammatory mediators, immune infiltration, and angiogenesis in a mouse model of rosacea. So they looked at combining 590 and 830 nanometers. So that's more into the blue and the near infrared. I don't know why they didn't use red. They looked at the severity of redness and inflammatory cell counts, the expression of key inflammatory mediators, the degree of angiogenesis, and immune cell infiltration of the skin lesions. And they were monitored by staining procedures. And they found results that PBMT significantly decreased the erythema score, so the redness scores and the inflammatory cell infiltration of rosacea lesions in mice. Further studies revealed that PBMT downregulated increased expression of inflammatory mediators and angiogenesis markers and attenuated the dysregulation of immune cell infiltration in rosacea. So they concluded that PBMT can improve rosacea condition by regulating these key inflammatory mediators, as I mentioned earlier, and dysregulating immune infiltration and angiogenesis. This one just came out. Actually, to be honest, this is why I'm doing this topic, because I looked at this paper and go, oh, wow, like there's a nice little review on photobiomodulation for the treatment of rosacea. So what they did here was a review study, right? So they looked at photobiomodulation. They, looked to see what was out there and sort of made some comments. I mean, it's not overly scientific like a clinical trial, but it's still relevant. So they looked at different articles on PubMed using these keywords, and they did a data analysis to list the conditions for applying photobiomodulation and looking to see if it could help therapeutically. So based on clinical and experimental studies assessed, photobiomodulation could decrease the hallmarks of rosacea and symptoms by, again, decreasing pro-inflammatory factor expression, inflammatory infiltration, immune cells, and promoting extracellular matrix remodeling. So basically helping the skin health. However, they lot of studies on it, and they tend to be experimental and clinical models. So therefore, we need more human trials to really get a handle on the dosage or the dose of light and the parameters that would be most helpful. This paper looked at LEDs that are, I mentioned these earlier, like toll-like receptor 2 and cathelicidin expressions in keratinocytes and rosacea-like mouse skin. So it was a mouse model. And they looked to see if LED had any effect on these keratinocytes. They used red and near-infrared wavelengths to see the expression through mRNA of these particular markers. They looked at protease activity and they found it was suppressed at 630, 850, and 940. They also found that these markers significantly decreased at 24 and 48 hours after LED irradiation. And again, it was performed 3 times over the period of the experiment. And they also found that cyclic AMP and interleukin 8 and protease activity were all lower than the control groups. Actually a good thing, marking inflammation. So they concluded that these wavelengths can help regulate these markers of inflammation and protease activity. And they feel that LEDs can be a promising treatment for rosacea. But yes, we need more clinical trials. Okay, so speaking of how to treat, with respect to the BioFlex laser therapy equipment that you may have, I'm showing you the large dual array. We have different versions of these and 2 laser probes. And I will say this, the bulk of the treatment is just going to be the LED dual array. I'm not going to recommend a probe unless you have the red probe, and I'll talk about that shortly. We do have a dermatological protocol, and I've used it as a base. Essentially, I've made some slight modifications here, and I'm going to talk about that. So this is a standard dermatological protocol that we typically use for acne and striae and different skin conditions, although we do have other ones for eczema and dermatitis, but I'm focusing on this one. So in stage 1, I'm going to recommend that's 10 minutes of red continuous wave and about 10 minutes of near infrared. Now, if you're stuck for time or what have you, you can reduce the near 6 to 8 minutes as opposed to the 10 minutes. But the 10 minutes of the red is probably the most important, mainly because the red is what's going to really saturate the skin layers. I'm not going to suggest you use the LDI 200 if you have the LDR 100. And some of you may not necessarily understand or be aware of our red laser probe. It's used for laser acupuncture. It's used for analgesia because it targets pain receptors. It's used for any superficial conditions just underneath the skin, and for wound healing and for skin. So like scar healing, that kind of thing as well, it comes in handy. So if you do some of that, you're interested in that, I would suggest that you pick one up. That would be my suggestion. Of course, you probably have to pay for it, but anyway. So if you have the LDR 100, I suggest you set it about 50% and roughly 5 seconds per point, just on the most affected areas, not the whole face, but just the most affected areas. Moving on to stage 2, you're going to modulate the red 100 hertz, so 100 cycles per second, 80% duty cycle. Everyone's quiet there. Are you guys asleep or what's going on there? Maybe type in some questions because we're getting to that very closely. Unless you're falling asleep, I don't know. And 80% duty cycle for 10 minutes, and then the dual plus near infrared, 50 hertz, 80% duty cycle. So we're just increasing that a little bit, again, for about 10 minutes. Well, I'm going to say 6 to 10 minutes would be good. No LDI 200, and you can adjust the LDR 100 now, maybe up to about 70%. Same things, 5 seconds per point. On the stage 3, now we're going to really alter the frequency, 1,000 hertz, 90% duty cycle for the red. You might say, well, what does the pulsing do? Really what the pulsing does, it seems to stimulate the ability of the mitochondria in the cell to use the energy. And sometimes these cells become accommodated to the light, like they don't react to it as well as they're being treated. So by modulating it, they seem to react better. If you've ever had a TENS or EMS, it's kind of similar to that, where you get used to it over a period of time and you have to crank it up or whatever. Same kind of concept, but a little bit different. Dual near infrared, 250 hertz, 90% duty cycle. Again, I'm going to say 6 to 10 minutes is good. No LDI 200. And again, you can shift it up now to 100% of red. And again, just on the most affected areas and only for a few seconds, up to 5 seconds per point. A few treatment tips about treating this type of condition is that, I'm going to back that up. You should ensure the skin is clear of any oils, creams, or makeup. If the patient's applying or any topical medication or taking oral medication, make sure you check to see it's not photosensitive. Extremely rare that it would be photosensitive to red and near infrared. Almost all medication, when it says it's photosensitive, it's ultraviolet. But I don't know. I'm not a pharmacist, so you can always to their doctor to ensure that it's not interacting with the wavelengths we use, which is 660 and 830, 840 nanometers. But I've never heard of that kind of interaction before. And if you do have it, I would use the dual flex array because it's nice and soft and pliable and silicone. And if you don't have it, you might consider getting one, especially for treating around bony, bumpy areas, sensitive areas like the face, that kind of thing. It's again, I'm not here to, tell you what to get. I'm just here to recommend. Maybe I am, I don't know. I'm here to recommend make it easier on your patient. So these flexible arrays are a little bit easier on the face and they can contour a little bit better. And also, as I mentioned, if you're treating other bony areas like the elbow or the ankle, that kind of thing, they make better skin contact. So if you're in the market for another array, I would suggest getting the dual flex. When you're treating the face, I do suggest that you use sterile cotton eye makeup pads over the closed eyes and then apply the blockout goggles. That way it's 100% blockout. This is especially important when you're using a laser around the face. Plan-wise is pretty typical, 3 times a week until the flare-ups are really improved. And then you can start going down to twice and once a week. And I would do some maintenance and hopefully improve the health of the skin and reduce the frequency of the flare-ups. All right, well, that's it for today. I haven't put out the list of the next webinars because I've been pretty busy and I have a lot of stuff going on in the summer, so I don't think I'll be doing as many webinars, but I will be doing a few. Any problem over moles or freckles? Nope, no problem at all there. I wouldn't put a red laser probe, a dark mole, however, because it can warm it up a little bit. So I guess I would recommend that. I'm new and just started using the BioFlex. Do you recommend treating the gut first? And if so, how long? Oh, I didn't mention that. Good point. I don't think it matters if you treat it first or not or whatever, but I do recommend that you can add that gut to help the inflammation in the gut biome. So it's usually applying a couple of arrays over the gut, and I have some webinars on that. So again, timing doesn't matter, but you can certainly treat the over the abdomen and essentially through a systemic kind of effect help the gut inflammation, which there is a link. I didn't get into a lot today, but there seems to be a link to a healthy gut biome and rosacea and certainly lots of other conditions as well. Okay, someone said I'm explaining this quite well, so they don't have any questions. Oh, well, that's I appreciate that. All right, well, that's it for today. So I really appreciate you joining in for today. I hope you have a wonderful day. And should you have any questions about buying stuff, like I mentioned a few things, just reach out to our sales team and they can help you with that for sure. And we'll see you next time. Take care, everyone.